Hey, this is Dr. Erdman at Madison Vein and Laser and Madison MediSpa. Today I want to go on to talk about treatment of branch varicosities in patients who come in with large varicose veins. And as we discussed in the last video, if you have the big, bulgy, ropey veins that you can see on the surface of the skin, typically what you're going to be seeing there is the branches that come off the two main trunks that we talked about last week, the great saphenous and small saphenous veins. There are really two main treatment options that are available to people today to treat the branches. One is called ambulatory phlebectomy. The other is called ultrasound guided sclerotherapy. They both have their uses, but as I will discuss today, they're better used for certain purposes, and most people are going to be better served by the latter of the two, which is ultrasound guided sclerotherapy. That having been said, let me start with ambulatory phlebectomy. So phlebectomy is a surgery where we make a series of very small incisions right along the course of the vein that needs to be removed. We hook that vein out, clip it, and slowly pull it back out of those small incisions. Now, it sounds a little bit grosser than it really is. Oftentimes, the example I'll use is a woman will come in and tell me that her daughter is getting married in 3 months, and she wants to wear a certain dress to the wedding, but she has a large vein across the front of her knee, and is there anything I can do in that short time frame to just make that look nicer? And for a patient like that, ambulatory phlebectomy is great. You can quickly go in, get that vein out of there. Healing time is short. It's not like the big surgery that we discussed last week. Again, very minor intervention, and you can get a quick cosmetic result. Now, ambulatory phlebectomy, microphlebectomy, any type of phlebectomy has great limitations in that you're very restricted to how many veins you're going to be able to get out of the leg over the course of the surgery. Some doctors prefer to do it under general anesthesia, and again, that to me is just overkill. Nobody should have to go under general anesthesia for any superficial vein procedure. So if you have varicose veins of any kind, you should never let someone put you under general. That having been said, again, some doctors do it and they dig around in their patient's leg for much longer than I would recommend. So I feel like it's just primarily a cosmetic quick fix. If you have symptoms of any type, if you have more extensive varicosities, not just one or two that are bothering you, generally phlebectomy is not the best option for you. So what is the best option? Well, for most patients, it's ultrasound guided sclerotherapy. Most people are aware of sclerotherapy or they've heard of it in the past. Sclerotherapy is injecting a vein with a medication to get the vein to scar down and go away. Historically, it was primarily used on small spider veins, but over the years, we've been able to actually bring it along and treat larger. What's allowed that is the application of ultrasound to this field. Now, when I was training, I saw plenty of physicians who would go in and they would do a surgical ligation and stripping, and their patients would come back with some leftover branches, and those doctors would try to inject the branches with medications to scar those veins down. And those physicians would do injections from the surface of the skin with traditional sclerotherapy, not ultrasound-guided sclerotherapy, in the hopes that they could get those residual branches or leftover branches to scar down and go away. The problem with it back then was it was not being done under ultrasound, and so it was just guesswork. They would say, oh, I injected a patient just like yourself, your same height and weight, and based on the results that I had on that patient, I'm going to try to do the same thing for you. Horrible way to treat people. You had no idea, you were just guessing. There was plenty of times where you were injecting a medication into the vein. You didn't know how far that medication traveled. You didn't know where to line up for the next injection. You didn't know if you put in too much or too little. If there was a vein that was deep to the surface, you probably missed it. So success rates in the past for sclerotherapy on large branch varicosities weren't very good. What changed that was ultrasound came along, as I said earlier, and was applied to the field, and now that took away all of the guesswork. So not only do we know where everything is in your leg before we start treatment, we know where all the good veins are, where all the bad veins are, we know flow patterns, we know everything before we start, and we can use ultrasound while we treat to guide our injections. So we can line up over a vein, even if it's a vein that's deep to the surface. If we found that it was broken on your scan, we can quickly find it with ultrasound, line up over it, inject our medication into the vein. And the really cool thing is you can see the medication on the ultrasound screen. It lights that screen up bright white. So we can see exactly how far the medication travels. We scan over the vein. Wherever the medication stops, we stop, line up for the next injection, and so on along that vein until we can very objectively say, yeah, you have great coverage throughout the veins that are broken. You're going to have a nice result. Or no, we don't see any medication in this vein yet. We know it's a broken vein. We better do another injection or you won't have a good result. So it's taken away the guesswork that used to be a problem for sclerotherapy. And it allows us to be much more comprehensive with our vein treatment plans than ever before, because we don't have to put you under general anesthesia for that. We're not on the clock. We can take as long as we need to. We can quickly find and treat all of the broken veins that you have in your leg so that we're not leaving something in there to cause problems in the future. It's really one of the least invasive treatment options that's currently available for varicose veins, and it's one of the things that we do the most of. The other great advantage to it is that it's one of the few procedures that actually has what we call reach. And what that means is that not only will we be treating the branches with ultrasound guided foam sclerotherapy, but as we undercut all the little spider veins that you may have in your leg, of course you're going to get some medication out into those spider veins, and the spider veins are going to start to be better too. Now, I never tell people all of the spider veins in your leg are going to be gone simply because of the ultrasound guided sclerotherapy that we're going to do. But at the very least, many of those spider veins that have direct communications to the branches are going to be better, and some are going to be gone completely. So that's important because usually that's where your insurance company will draw the line. Most insurance companies will cover treatment for the trunk and treatment for the branches, but they'll say we consider all spider veins to be cosmetic, even if they're causing symptoms in your leg. And so a treatment that actually can affect both the branches and the spider veins is really important because it can save you a lot of out-of-pocket expense and really minimize what you have to do on the cosmetic back end of the treatment. In my experience, ultrasound-guided sclerotherapy is the single most important thing that a physician can offer to their patients so that their patients are happy when they're done with treatment. So many people that we see who have treated at other facilities where they only treat the trunk, or maybe they do the trunk and a little bit of the phlebectomy for the branches, come in and they feel like their treatment is incomplete. Time and time again, we see people who come in and they say, I thought that by doing this surgery or by doing this whatever other procedure, that all of the veins in my leg would be better, or at least significantly better than they are now. And they're disappointed because they feel like they've only been partially treated. And that's exactly what has happened. They've had partial treatment, but they still have a lot of leftover branches. And really, those branches can only be treated with ultrasound-guided sclerotherapy. The other pitfall that we see is some surgeons will surgically remove that great saphenous vein. And because that's all they offer, then they'll send their patients to a dermatologist to try to inject the leftover little spider veins. But the issue is no one has treated those sort of medium-sized branches in those patients' leg, and the dermatologists will never have a chance, because what'll happen is they'll inject those little spider veins, or they'll try to do surface laser on those little spider veins, and those underlying leftover branches that weren't addressed during the surgery just reopen all of the little spider veins. And so those people feel like they wasted a lot of time and money on a treatment that just never had a chance to be successful in the first place. Now, you may think, well, why don't all physicians do ultrasound-guided sclerotherapy? And it's really simple. It's a time-consuming procedure that's not well reimbursed. And so a lot of physicians aren't willing to do it. The difference with us is we specialize in vein treatment. And I really feel strongly that if you don't offer ultrasound-guided sclerotherapy, you shouldn't be specializing in vein care, because you're going to have a lot of patients who are very unhappy and feel like they were only partially treated. So ultrasound-guided sclerotherapy, in my book, is one of the most important things that you can be offered on a menu of services for varicose vein treatment. Now, the last thing that I want to talk about with ultrasound sclero is what types of medications are used. Now, typically any physician specializing in vein treatment is going to use one of the two main FDA-approved medications for sclerotherapy. They have big, long names. One is called polydocanol, the other is called sodium tetradecyl sulfate. Basically, they're both fancy soaps. And what they do when you inject them into the vein is they cause inflammation of the lining of the vein wall. And in response to that, the vein spasms, the walls scar down and go away. And so the analogy I use here is, think about if you're taking a shower and you get a little soap in your eye in the shower, it would make your eye red and inflamed and you'd kind of squint until you felt better. Same thing, we inject into the vein becomes inflamed. In response to that, the vein spasms, so it's like when you squint. The difference is that the soap that we're using is much more concentrated. It causes much more damage to the endothelial lining of the vein wall than the soap would in the shower that I was talking about. And it causes that vein to actually scar down and go away. There's a couple other medications out there to be aware of. One is hypertonic saline, which is a super concentrated salt water. That is not useful at all for the bigger branches. You're actually limited in volume to about 5 cc's per treatment. Otherwise, people have horrible leg cramps from all the salt that you're dumping into their leg. It's also quite painful. And even for smaller spider veins, it really has limited efficacy. So I usually tell people to try to avoid hypertonic saline. Saline injections for spider veins is one of the most common, it's one of the most ubiquitous things out there, but generally not a great option. You'll see a lot of people who dabble in vein treatment use saline sclerotherapy, but people who specialize generally avoid saline sclerotherapy just because it's not very effective. And then the fourth one that's out there is called sodium moruate. It's actually a fish oil. It's a fairly effective sclerosant. However, there's a relatively high incidence of severe allergic reaction called anaphylaxis, and it's a life-threatening type of allergy. And when you have the two that I mentioned to begin with, STS, sodium tetradecyl sulfate, and polydocanol, there's no reason to find out if you have an allergy to sodium moruate. It's just, there's not a significant benefit to it, and really, when you have a life-threatening downside, I tell people to avoid it. All right, so that's treatment of the big branches that come off the trunks. Two options, again, phlebectomy or ultrasound-guided sclerotherapy. As I said, phlebectomy has its place in a limited number of patients. If you come in with 1 or 2 big bulgy veins and it's primarily a cosmetic issue for you, phlebectomy is a good choice. If you come in and you have lots and lots of both branches and little spider veins, ultrasound sclero is going to be better for you. And if you're